Good morning. I'd like to call the meeting of the Managed Care Committee to order. Madam Secretary, would you please call the roll?
Director Harrington?
Present.
Director Story?
Present.
Director Webster Cross?
Present.
And Chair Curry?
Present.
You have a quorum.
Thank you. I'd like to ask for a motion to allow Director Webster Cross to participate remotely in this meeting as a voting member.
So moved. Second.
It's been moved and seconded. I'd like to ask for a roll call. All in favor? All opposed? The ayes have it. The motion carries. The next regular meeting of the Managed Care Committee will be held on Friday, April the 19th. Madam Secretary, has anyone registered to provide in-person or virtual oral testimony or submitted written testimony to be included in the record?
I didn't receive any registrations nor any written testimony.
Thank you. With that, I'd like to move to agenda item 3, the report on health plan services. We have Mr. Aaron Galliner, Chief Administrative Officer of the Health Plan Services. He will review the report and metrics. No action or motion is required. We are only presenting information. Mr. Galliner.
Thank you, Chair Curry. The first slide just covers what we're planning to walk through today as our agenda. This will include our health plan metrics, a review of some of the accomplishments over the course of 2023 since we're heading into our new year, and also what areas we're planning to focus on for fiscal year 24. We'll also do some specific pullouts on some of those initiatives to go into a little more detail, and then we'll wrap up and cover additional questions. With that, we'll start with our usual metric slides, including our first slide of membership. So total members through, this is as of January 5th, 24, is 432,000 individuals. You may recall that this is actually an increase from December, and we'll cover that in more detail in a couple slides. This next slide shows our market share data, still at the 32.3% mark. This data is only through October, so a lot of the redetermination data hasn't kind of flowed through this impact yet, so we'll be interested to see how this shifts as the state publishes some additional data. The next slide shows our trend versus the overall managed care market. You can see it's pretty much spot on with the same trend as it has been for the past 18 to 24 months. You can see the overall market is declining along with our membership as redetermination really started in July and August. The next slide shows our membership versus budget. As I mentioned, you can see the increase in the orange bars from December to January. We're already at this point significantly ahead of our budget, which is great news. That's really due to two things at this point. One is performing better than originally expected on the retention rate through redetermination. And then the second aspect is the shift of the health benefit for immigrant adult population into managed care. And we'll talk about that more in a few slides as well. This slide shows our operations and call center metrics. You can see we're performing within our expected SLAs here, including an average speed to answer, abandonment rates, and calls answered within 30 seconds. We've been highly focused on these measures, especially through the redetermination process, because we don't want individuals to be waiting on hold while they're trying to work through what's already a complex process with their READY paperwork. Also, claims encounters acceptance, which is data we're required to submit to the state on each of our encounters, is holding at the 98% required acceptance rate.
Mr. Gleaner, just a question relative to the operating metrics. Is it correct that all of the member services, these call centers, is that internal now? Have we completed that transfer, or are we still working with a third party?
We still utilize our third-party administrator for the call center, but we did do a transition previously on the subcontractor relationship. But this is all housed with our third-party administrator.
Okay.
The next slide shows our utilization per thousand. Orange bars is current period, orange bars is prior period here. Blue is current period, and then the light shading is projected. We continue to see utilization generally on a downward trend year over year. I will note that as redetermination continues to impact our overall membership, we're going to expect that this trend will reverse and that we'll start to see some increase in the utilization per thousand as healthier individuals tend to redetermine at a less at a lower rate than individuals that have higher acuity issues. The next slide shows our COVID vaccination rates. The state has held pretty stable really for the past year now at this point. We're continuing to push out education materials, and we've combined a lot of campaigns around the flu vaccination, COVID vaccination, as well as RSV for targeted populations. And so we're continuing that outreach and engagement, and we're able, especially as we do work around redeterminations and engage people through that process, we also try to capture and provide education around other health issues that they may have, including the opportunity to vaccinate. Next slide shows our claims payments trends. You'll note that this has ticked up here, which tends to happen at the end of our county fiscal year, and then we usually see that drop back down, and so we expect that trend will reverse here as this data extends out through January. We expect this to come back more in line. The next slide shows our claims payment trends broken down by aging. Again, you see most of the aging increase in that 30 to 60 day category. Really, we want that to be down to 0, which is the goal, to stay within our 30-day requirements for timely payments. Again, that tends to tick up as we go through the budget rollover, and then we look to pay that down over the course of late December and into January as the systems open back up. All right. We'll transition now into review of our 2023 successes. This is really an opportunity for me to first and foremost thank the great work of our team. We have an incredible staff that's both really dedicated and committed, as well has great experience and knowledge. And I think this slide speaks to a lot of our efforts over the past year, in particular in a year where we went through our NCQA reaccreditation as well as redetermination. The ability of the team to drive forward on a number of these other initiatives, I think, is particularly impressive. So I would like to acknowledge all of their hard work here. I won't read each of these off the slide, but I do want to call out a couple of these items. Based on the NCQA quality ratings, we had the highest score among MCOs. We saw increases in our CAP scores, which are consumer assessment ratings, so member experience ratings for the health plan. Those in particular are 2 areas that we were highly focused on over the past year. We hit our highest membership ever in the history of the plan at 457,000 right before redetermination began again. Another one that has been really critical for us is we had a lot of success with hiring this past year. We hired over 230 positions into the plan. This is mainly around our care management teams, and so we've been able to transition from what used to be a highly contracted staff in terms of the care management teams into much more internal employed staff, which is really great news. That's been something we've been focused on, and the team is much more stabilized at this point, given the kind of volume increases that we've had. I'll also highlight a couple initiatives on the health equity front that we've been really proud of, including our food care program that we rolled out this past year. So over 23,000 members have engaged with that program. We have over 1,300 members at this point receiving medically tailored meals, and then a large number of individuals that are receiving nutritional education and assistance through the platform. We've also continued work on our housing and flexible housing pool, and we're actually in the process of going through an RFP to look at building a more holistic housing approach. So not just the far end of the spectrum, which is what the flexible housing pool is with permanent supportive housing, but also looking at things like eviction prevention assistance, rapid rehousing, and trying to really build a spectrum across the different housing needs for our population.
Mr. Gleaner, in the parens ARPA quality withholds, could you speak to that a little bit? What that?
I'm sorry, could you say that again?
Under the flexible housing pool, ARPA quality withhold.
Yes, so that's the investment dollars for that came from a combination of ARPA funding that the county received and then reinvested both across Cook County Health and County Care. And then the other source for some of that funding that we used was quality dollars that we received back from the state.
Thank you.
All right. So I'll transition now into the 2024 areas of focus, and really would.
Before you move on, I have a question. The member demographic initiative, what is that?
Yes, thank you for asking about that. So what we have found historically is that the total information we get on our members, particularly as they originally enroll with the state, that's the initial source of most of the data. So things like language, race, ethnicity, a lot of that's incomplete. And so in order for us to better serve our members, we went through a process of really working across our different vendors and different touch points that members have, be that providers, pharmacies, when they interact with our call center, to be able to compile that information back to a single repository so that we're better able to capture things like language preference, for example. And that actually was something we pursued heading into the redetermination process so that we'd be better positioned for redetermination. So we see, for example, much better engagement with members if we text the member in their preferred language. We get much better initial engagement rates with that text than if we, send out a text in a non-preferred language. So these are 2024 action initiative areas. They're, organized by the same strategic pillars that we operate under as Cook County Health. A lot of these, I think, are things that you've likely seen over the past year. A number of these are continuing focus areas of behavioral health, for example, maternal and child health. We really, in kind of total, are really driving the plan towards moving up to being a 4-star quality plan. We just missed that cutoff this past year, so I think we're really well positioned to achieve that this year. And these are specifically focus areas that we have opportunities in order to move up that overall quality rating. We will continue, as I mentioned, building out our housing programs. We've started initially building some domestic violence reduction programming, which we'd like to enhance over the course of this year. We also have transitions for our non-emergency medical transportation, as well as an RFP out currently for our dental and vision vendor. Those are both areas that we get a lot of feedback on from members, especially non-emergency medical transportation, about just the overall experience. That tends to be a challenge in the Medicaid market generally, but that's also an area where there's been a lot of innovation recently, particularly with on-demand transportation options. So we're excited about the possibility of going back out to market for both of those areas and seeing what's available. We're also continuing to really push into telehealth and virtual care, which we'll talk about more in some upcoming slides, as well as, of course, continuing our READY work. We will also talk more about the health benefit for immigrant adults, which is a new population that we're welcoming into the plan and certainly has unique needs that we're focused on as they transition in. We're also continuing to build out in partnership with CCH, the Cook Medical Group and CareLink programs. These are some unique programs within the health system, one for uninsured and one for partnership program with Blue Cross if individuals choose Cook County Health as their medical home. And then we're continuing a lot of work that we've built out and structured over the past couple of years around employee engagement work. We've really measured staff satisfaction over the past few years and have gotten a lot of great feedback through that process. So we've had really strong engagement and satisfaction scores, but of course there's always opportunities for us to improve, including how do we think about performance management, professional development, and so those are areas that we want to focus on. And then of course, financially, we have, as I've spoken about before, our medical cost action plan initiatives, which I think probably in this next quarter's meeting, we'll do a much deeper dive around, as well as continuing to push forward in our value-based contracting strategies. So there's a lot there, but I think we're, again, really well positioned heading into this year to move a number of these items forward, and we're excited about that opportunity. The next slide goes into a little more detail on some of these, and I won't, again, read through each of these here, but wanted to give you a sense of, what are some of the specific measurable targets that are behind those broader initiative areas. And then these are things that we'll be coming back to you with throughout the course of this year to report out on in terms of how we're moving forward in these areas. So some examples of that, like if you look at the fiscal resilience category, for example, we have a value-based care contracting focus area, and so our target is to achieve 64% of our medical spend in the category 3 to 4 advanced payment models, based on the LAN model, which is a standard methodology for evaluating those agreements. And effectively, the category 3 and 4 is the highest level of value-based contracting, which involves, shared risk or shared global savings based on total cost of care of the population. So we're currently closer to around 50%, so this would be a significant step forward. A course on member safety and health equity. These are, again, focused on things like engaging our population, connecting them to preventive care, and then highly focused on our behavioral health measures, which I spoke to previously, as well as our maternal child health measures. And then the other opportunities that we see are really around moving more into disease management, so a focus on areas of chronic disease such as diabetes, blood pressure, asthma. And certainly welcome the committee's feedback as we think about what areas we plan to focus on over the course of the next year. Okay. Next slide. So wanted to go deeper into a couple specific initiative highlights. So the first is around our network and our focus on our strategy around networks. So just to level set before we go into that, we've got a pretty expansive network across the county. You can see we added a number of new providers into our network over the course of 2023, and those really aligned with some of those key strategy areas that I mentioned. So you can see behavioral health is the top area there where we added new providers into the network, and that's really trying to expand behavioral health access into our county care population. So we also continued to build on primary care as we continue to see opportunities to grow the plan, and then post-acute areas also continued to be a focus area for us as we looked to build out transition of care opportunities. The next slide.
Aaron, excuse me, before you see this slide 19, who actually talk a little bit about the process of with respect to the addition of the new providers in behavioral health. And how do you achieve? How was that achieved? Do you have someone on your staff or?
Yes, we have a contracting team that focuses on the provider network. So there's a couple different ways that can happen. Providers are able to apply into our network, and generally, as long as they meet our requirements and willing to accept our standard rates, they're added into our network. And then, of course, we also then look more strategically at our network and geographically where we see areas that access may be more limited. We'll do more active outreach and engagement in those areas to try to add providers to the network.
What is because of the unique status of county care in the state of Illinois, the Insurance Commission, what does it say about providers? You explained this to me once, just remind me. Individual practitioners have to be what in terms of the credentialing process?
Yeah, so the state has a bit of a unique process. So we don't actually do credentialing at the plan level here. The state of Illinois, through the Medicaid enrollment process for providers, that enrollment process is treated as the credentialing process for Medicaid health plans in the state. So once they're enrolled as a Medicaid provider with the state, that is, we are required to count that as meeting our credentialing requirements.
Yeah, thank you. Just a reminder. I know you shared that with me once before. There's no formal credentialing process at county care. It is once the state gives us thumbs up.
Correct. Certainly, we do additional checks as they come in. Background, OIG, checks, those sort of things with our compliance team. But for the what you would typically think of as the credentialing process is handled by the state.
Aaron, I have one other question. With this addition of these new provider organizations, again, to Director Story's point with behavioral health providers, have we seen a positive impact in terms of closing or shortening the length of time it takes for members to actually get in for care? And I know that gets reported somewhere else, but what have we seen relative to actually getting people in sooner when these types of services are?
Yeah, I would say it's still certainly a challenge. I think one of the things we're trying, or we've tried to develop over the past year, is how do we truly measure that access? So in the past, we've had a lot of things like provider surveys where the providers themselves are reporting the access, and of course we get data back from member surveys, but those tend to be a little more generalized and harder to get to specifics around particular providers. So one of the things we did this past year was contracted utilizing the Press Ganey broader contract, where they will actually do kind of like secret shopper calls to our network, so that we can get more actionable data by specialty on what the access looks like. So we just started that process about 6 months ago, so we're kind of getting a good baseline now and should be able to report back on that next year.
Yeah, I'd certainly like to see that as one of the strategic measures or metrics that we're looking at starting from January 1 and going forward, what direction that's going in, so we can say definitively that we are making some positive inroads. That's a critical need, especially in the behavioral health sphere. Yeah. They're all important, but behavioral health is one that we want to look at closely. Thank you.
Yeah, happy to report that. Okay, so moving into some of the strategy goals of the network. If you want to go to the next slide, Deb. So
Just as a point, apologize once again for dragging on on your presentation, but just once again for clarification, the provider organizations, ancillary skilled nursing, once again, they go through the same process at the state level. So if the state approves them as the person, they're eligible to participate in this program.
yes,
So if for some reason, if the state misses something and you can't, then you go back to
to the state. Yeah,
say, hey,
Correct.
with all due respect, we identified this abnormality, this licensure issue, or this quality issue, and we would like for the state to reconsider approving this entity to participate in the Medicaid Managed Program. Yeah.
correct.
You have the option to do that.
Yes.
Okay. And that's just not for the providers, that's for the skilled nursing facilities, and waiver providers, and ancillary providers as well.
Yes. So at a high level, the key components of our overall strategy. So I mentioned telehealth before, something we're aggressively pursuing over this past year. Continued evolution of our value-based agreements. We are looking to build out more infrastructure around how we manage our network and evaluate their performance. Continue to think through how we engage with providers and how we want to strategically expand the network. Network data management and technical improvements there, including things around provider rosters, our provider directory, and then a focus on specialty care access initiatives. So on the next slide, we'll start with the telehealth strategy, and this is really around access to care. And so the first priority here is really behavioral health, as I mentioned. So likely you'll be seeing at the board over the next few months us bringing some contracts to you around telepsychiatry, and then later in the year around more on-demand care opportunities through telehealth, and then as we head into next year, the potential to add some more specialty telehealth beyond those two areas. I'll also note Cook County Health, of course, is also expanding with its virtual care capabilities. And so one of the things, particularly in that phase 2, around more on-demand care access, we'll also be looking at how we layer that in and think about the approach, because I think there's a lot of good opportunity there for us to collaborate with what the health system is doing to offer that kind of access. Okay, on value-based agreements, of course, we don't just want to do value-based agreements to say we're doing value-based agreements, but there's some specific goals we have underlying those type of contracts. And, you know, first and foremost is always to improve the quality of care that our members are receiving. And so the goal of the value-based care contract is to be able to better empower the provider to provide the best care that they can when they're with that patient. So it also, you know, provides opportunities to enhance member experience. We're able to provide better wraparound support with things like care coordination. Of course, there's a financial component to all of these agreements, both in terms of, you know, what is the direct reimbursement to the provider, but also from a broader perspective of how are we managing the overall risk of the health plan, and how do we shift some of that, you know, insurance risk to de-risk the health plan and not have 100% of that sitting with us at all times. Of course, we are moving more and more into building in health equity into these value-based care agreements as well, and want to do all of this in a way that positions us to operate sustainably going forward into the future.
Excuse me, what's the process then going forward for a particular provider to engage in contract negotiations with you around value-based care for a particular disease? Because you mentioned something like this before.
Yeah, so one of the things that would
you carve out a patient population like those involved in metabolic disease, like diabetes, cohort of patients? How would that sort of look like? What would it look like in terms of a value-based initiative around the NPC?
Yeah, let me, by way of answering your question, let me take a step back for a little context first. I think historically we've had a fair amount of value-based care agreements with primary care providers that tend to be kind of total cost of care, kind of global type arrangements. And those have been with providers that have had, I would say, kind of a high level of capabilities. And then we've had a very basic program around things like some HEDIS incentives that just about all providers participate in. What we're trying to do the way we're thinking about managing our network and managing disease states is build some of the infrastructure as a plan that can better assist providers that maybe aren't too that far into the spectrum yet, but are wanting to move up the capability matrix of how they can, you know, handle risk or handle a value-based care type of agreement. So that's one aspect, and that really gets into like how do we share data, what kind of tools do we have for the providers, and how we can kind of work with them collaboratively. So that's just on mainly on the PCP side. And that's historically where a lot of our focus has been. What we've had much less of is specialty care, value-based care agreements. And I think that's where a lot of opportunities for us lie, getting more to your exact question. And in particular, how do we manage some high-risk disease states that perhaps you know, a PCP may not be the best positioned to manage. So there's you know, certainly opportunities as we look across the network and some of those high-risk areas. CKD and ESRD is, I think, a great example of that. You know, how we look at things like how you manage transplants and CKD, for example. So I think there's a number of opportunities around some of those creating kind of high-cost medical home models, or high-acuity disease state medical homes. For some of those specific areas, we've gone through more specific procurement process for. So the ESRD CKD area, again, is one that we went through an RFP process for, and are moving to implement a vendor that focuses especially on that population. And we'll likely continue to do that for some of those areas. Oncology, for example, is another one, some high-end cardiology, those sorts of things.
And to piggyback on what Director Story asked, and I'll use hypertension and diabetes as an example, because they're the major causes of kidney disease in the country. And so we have people that have some diseases to some degree. Hypertension is asymptomatic, and diabetes, people don't know they have it until they're diagnosed. And with all the touch points we have with patients, what efforts are we making to actually increase utilization of the primary care that's available? That's what I would be interested in, because some of this can be prevented if people are having routine visits with their doctor, if people are having the screenings that are recommended at certain ages. A lot of this could be prevented moving forward. And so we have a lot of opportunity and touch points with patients. So what are we doing to reduce the likelihood that these things will occur?
Yeah, thanks for that question, Director Harrington. So, I think, and you saw it on a previous slide, one of our first and foremost measures that we always look at is the AAP measure around how many of our members are engaging with preventive care. And so that's something that we've, we've been excited to see has progressively increased over the past couple of years. Certainly there's more opportunities to move that number higher. But there's also some opportunities for some disease management programs and care coordination programs at the health plan level to help provide some of that wraparound support for some of that preventive opportunities where it's before it's at that higher specialty level. And certainly, as we continue to work with our network and move into value-based care, additionally with the PCPs, that's part of the goal of those agreements, is to help better position them to help both, like, how do they engage and make sure that their patients are getting in, and then how can we best position them to engage with those patients, help support them with follow-up, testing, all those things. And that's where a lot of the care management wraparound comes in with the PCPs.
Sure. Let me ask, both of those are very important points that were raised here. And the word I've heard the most here is opportunity. How do we get moving from opportunity, if we've identified these opportunities, to actually a forward transition to having maybe some discussions around this, what this would look like? We are a leader in taking some of these payment models, and there certainly are some organizations and provider groups out here on the primary and specialty side that have done well in these areas, maybe with other plans. So what I think would be important as we look forward to move from just these opportunities that clearly are here to actually having some discussions. Is that something that could occur this fiscal year coming, to get a schedule for sitting down with some of these providers could help move that needle?
Yeah, absolutely. I think we'd be happy to bring that back to the next managed care committee meeting, both to talk about what are some of those disease states that we're particularly focused on, and then what are some of the more specifics around, like, what are the providers we're engaging with around that opportunity.
I have a question for Dr. McItis, and obviously Aaron come in as well. As we talk about these, Aaron's given us a report out on the value-based agreement. Where's that intersection then with respect to the acute care operation and what Aaron has already initiated? I mean, because he commented on the telehealth and the opportunity to collaborate, so that's what sort of stimulated. My question is, if that work is already occurring with his operation and the ACHN, is the same effort being put forward in terms of value-based reimbursement on the acute care side with the practitioners?
Yeah, so I would say on the more traditional, kind of health system side, the hospital ACHNs were probably a little bit more behind than where the health plan is at in terms of offering, you know, payment models or on our side, taking payment models, right? That share risk. For example, you know, we've had early discussions around creating an ACO, looking at, you know, Medicare shared savings, kind of, you know, trying to get more into that space where Aaron and his team are at, in terms of the payer side. Yesterday, we, at the board meeting, approved a resolution around Westside United, which I think is going to create a very nice collaborative environment, and something that, you know, I would talk with Aaron about, you know, how do we engage from the health plan, and then, you know, he talks about wraparound services for care management. This is going to be kind of on the provider side. How are we collaborating with all of the, you know, local resources and teams, and instead of duplicating efforts, coordinating much better. So, again, I think the short answer is, we're looking there, we're making plans to move there, but the health system is, I think, a little bit farther behind.
Yeah, because, once again, for the sake of redundancy, apologize, but, the efforts that Dr. Collins and Aaron and the rest of the team are making, I just hadn't heard it from the other side. So I would hope that there's an intersection, you know, obvious, maybe to you all, and you're working to say, you're looking to collaborate more in this area around value-based, so that's good news.
Yeah, the health system strategic plan has that called out specifically of moving into value-based care.
That's the good news.
Yeah, just to add a comment to that, I think as those capabilities continue to be built out with CCH, I think hopefully County Care offers that ability to kind of be the test case health plan with them to you know, offer an opportunity to move into that model in maybe a little bit safer way before taking that broader risk out externally.
That's because, as most of you know, the dialysis unit, for example, a problem, small book of it, but working with a vendor who's, since I've been here, when we open up, we all open up the unit here, and they're not only providing for, you know, ambulatory, but they have inpatient, you know, I guess it's peritoneal and home training, I don't know. But that seems like that's an example of taking baby steps, you know, and to your point about testing it, you know, the smaller things before you go full board with it. I would see that as a prime example of what I'm not trying to put words in your mouth, but that would be a great example, of prototype, I should say, going forward to take that book of business, the problem in terms of, ambulatory dialysis patients that we do an inpatient. And I have a personal interest, just in the interest of full transparency, because diabetes in my family, and so my dad, my sister, my brother also come to this terrible disease, and we went through the whole process of trying to get off of dialysis, chemo, peritoneal, and unfortunately it didn't work for our family, but I think about a more comprehensive approach that you know, especially around value-based care when people are incentivized, right? You want to move people off of those machines and into a transplant program and then a normal life. So I hope that that's something that, in terms of the NDC, that you would look at. So between the two entities, I'll be interested in the report back out on that over the weeks and months. Since you already started that road, it'd be great to have an update specifically on what you're doing in terms of contract needs in that area.
Yep, happy to bring that back. All right, on the next slide, this just gives a snapshot of where we're at today in terms of value-based care, in terms of our overall spend across the health plan. Again, we've got, when you look at, and this is categorized kind of 1, 2, 3, and 4, and this is based on what's called the LAN model, which is a standard methodology that's used to look at value-based care agreements based on the components of those. So lowest being standard fee-for-service reimbursements, the second being fee-for-service reimbursement with some link to quality, such as pay for performance around some quality measures. And then level 3 moves into really looking at the providers looking at the total populations and not just what's happening within their 4 walls of care, but what's, how many times is their patient going to the emergency room, for example. And those consist of, things like shared savings, the beginning to introduce some level of risk, and then 4 is kind of the highest level of global capitation, taking a percent of premium, et cetera, where the provider's really taking on full or a very significant portion of risk, along with managing the patient population. So you can see sort of how our spend breaks down right now. We've got just under 50% that's in those categories 3 and 4, and that's really where we are looking to move that closer to the 65% level. And again, we're not just doing that to say we're doing that, but one of the things we see is a lot of differential in terms of the quality outcomes of the patients for the patients that are in these provider groups that are under these value-based care arrangements versus ones that are just in a standard fee-for-service model. The next slide just starts to talk about some of those items that I think we just covered in a lot of our conversation. So I think if you want to jump to the next slide, Deb. So the other component of our network strategy is really thinking about how do we build the right infrastructure around how do we analyze and proactively manage our network. And so this is just an example of that, but like how do we look at on the left-hand side, the kind of supply side, and then on the right-hand side, the left-hand side being like the demand side of where is our patient population, the right-hand side being where our providers concentrated for specific areas, as for behavioral health, for example, and thinking about how do we manage the network to try to match those and align those better to ensure that patients have the access they need and they have it locally and close to them. And so we've, of course, have a lot of analytics within the plan now, but one of the areas that we are looking to build out is specifically around how we use analytics to more proactively manage our network and manage towards those overall goals around quality, equity, and access. The next slide gets a little more technical, but just to give you a sense of some of the things we're working on. This is all about the underlying data that happens within our provider network. So at the beginning, we contract with a provider. That provider is, the contract information is, loaded and stored. The provider gives us their roster of all their practitioners. That information is loaded and stored, and then all of that feeds our downstream system. So our claims management system, our provider directory, it goes back to the states to their enrollment brokers, so that when an individual enrolls in Medicaid and they go to pick a provider, it's based on that list. So all of that comes out of the core systems of how do we take in and store that data. We have undergone a series of RFPs and appreciate the board's support and approval of a couple contracts over the past year that's really focused on enhancing this core process because it's fundamental to all of those downstream items. And so as you think about things like access for members, it really matters how accurate your data is in terms of what hours is the provider available and on what days. So what language does the provider speak? So all of those things really happen at this point of taking in this data, and then how does that get fed and appropriately put on our provider directories, available to our call centers when someone calls in. So this is really rebuilding this entire infrastructure to try to make this it's the most kind of user-friendly interface that we can. And eventually the goal is on the provider directory, and one of the contracts that we're implementing will have the capability to do is also linked directly into provider scheduling if the provider has that opportunity. So you'll be able to look up a provider on our directory, click into the link, and then click into actually scheduling an appointment directly. And so that's also something, as the health system builds out some of that functionality, we're excited because we'll be able to integrate some of that. And so members going to our website, trying to find a provider, will also have that ability then to hopefully directly schedule into CCH as well.
So Aaron, would it be premature at this point? My first feeling when I saw this was, this is something that lends itself to the new AI that's rolling out. There may be some opportunities here to answer or proactively anticipate some of these kinds of issues we run into through an AI. So have we done any discussions or looking at how we could integrate or begin building out an AI model? This seems to be where...
Yeah, absolutely. Certainly AI is a big topic, but some of these vendors have some AI capabilities. So that's one of the things we'll be talking through as we work with them and also with our HIS team on what's the appropriate use of that and how do we leverage that in a way that enhances what we're doing and is also being done in a responsible way. But yeah, there's certainly a lot of opportunity here. The tools they have also do things like identify exceptions where provider rosters are missing these particular data components, but there's a number of national databases that have a lot of this information in them, which can be drawn from. So there's a lot of opportunities to connect a large amount of data to really enhance what we're doing. So certainly AI is...
I was going to ask, I mean, they are putting AI capabilities in the hands of individual consumers now, right on your phones. And so I think on a large scale basis, this certainly represents one of those opportunities that we want to be out front on.
Yeah.
Thank you.
Yeah, we have an ongoing discussion now with Angelo Vanian and team on kind of a broader strategic plan in terms of a role. And, some surveys have gone out to the broader CCH team to see, what are some needs, where are opportunities, including the health plan, but again, the broader system as well. So we're trying to kind of measure all of that out and then decide, what are things that we can get a third party to come in and do for us, what exists already, or, conversely, what are some things that we might want to build in-house. We are fortunate to have a couple of UFC fellows right now who are, kind of programming AI experts. So they're helping the team right now to kind of do all that measurement and strategy adjustments. So.
Excellent.
A word of caution, where there are opportunities, there are also threats. And there's a lot talked about AI, but you also want to be careful as we move forward.
Machines are not.
Here we go.
I saw that movie also. The creation. No, I'm sorry. But let's talk about that. Excuse me, Chair. I just want a quick follow-up question. From my own education, with respect to the IT component, is county care operations a part of Angela's shop, or is it one and the same?
Yeah, they support you guys, right? Yep.
Yes. Okay.
Because I've heard about the work that, Israel talked about, what Cerner was doing on the front end, is the portal, patient portal, et cetera. So it's exciting. So I just want to make sure that we were, as an organization, CCHHS was fully integrated, or at least the awareness on both sides. Thank you.
All right, the next slide just gives you a sense of what some of those specialty care access initiatives are and some rough estimates around, what do we think is available in terms of, days that we can reduce in getting access to care to members, and then how many members that those may impact. So telehealth, and then, looking at what areas in our network can we convert out of network providers to in-network. How do we think about in-network provider alignment to optimize and work with them around their capacity, et cetera. So I think this Chair Curry gives you a sense of kind of what you were asking about earlier, but we can certainly bring back a lot more depth on this. Thank you. All right, the next slide moves us into an update on the redetermination. So as you saw earlier, we were starting the year off in a stronger position than expected in terms of membership, and that's really related to our outperformance on redetermination. So you can see the blue line there is around the 85% mark, which is the retention rate that we've had for individuals up for redetermination. We were initially projecting closer to 80% on that. So we've had pretty consistent performance around that 85% mark, which we're very pleased about. Certainly not satisfied. I think there continues to be additional adjustments we can make through our process. We've really pushed out into the communities at this point around community events and are able to target neighborhoods where we're seeing lower retention. And of course, we're continuing all of the other outreach and engagement infrastructure that we have and driving that forward. But I think overall, again, want to thank the team that's working incredibly hard on this, and so far I've seen really good results here.
Do we know how others are faring? Are we a leader? Are we in the middle? I mean, 85% is good.
Yeah, I think a couple comparison points. One's obviously when we had looked initially to set that 80% sort of initial expectation, that was based on some national information we had. We have seen periodically some comparative data with MCOs, and we have tended to be in the top 1 or 2 MCOs each month through that. So I think we're overall performing well. Again, there's always areas to improve there, but I think comparatively we've had good performance.
And I've seen the billboards and ads.
Great.
Eric, what's the closeout date for the Fed? Are they going to prove that at all?
No, so the redetermination is a standard process, so it will continue ongoing. This initial wave that's happening for individuals that haven't had to do it since before the pandemic, that really would run through July, would be the full 12 months of those cohorts, and then at that point, it would be kind of ongoing. So July is really that kind of end point.
July. Because I asked the question because when I hear about states like Arkansas who did this in 6 months, but they took a draconian method to there to just achieve that, complete that process. So is it to July 1st, June 30th?
Yep. The next slide just gives you a little image of one of our community events, and one of the things I wanted to highlight is we at these events aren't just engaging around READY, we're also taking that opportunity with the member in front of us to connect with them around completing their health risk screening, getting them connected with our care coordination team. We've done food box distributions, given them information about our rewards program. So we really try to take that opportunity to engage with them more holistically. We also, we do these redetermination events, but we also put out information ahead of time. And so individuals can register for the events, and we're able to pull down their paperwork and have everything ready to go when they walk in to help assist them through the process. That also gives us the opportunity, again, to look at, have they completed a health risk screening with us and better tailor some of the needs. But of course, if an individual walks in, we'll support them through the application process as well. Next slide.
Behavioral health summit on there?
It is not in terms of redetermination event. Certainly, County Care will have a presence there, though.
Okay.
The next item I wanted to update on was the health benefits for immigrant adults program. As I mentioned before, redetermination was driving a higher membership, but the other thing that started to impact our membership is this program. So the state started this program 18 to 24 months ago now, where they provided state-funded coverage to individuals that are ages 42 and over who otherwise would qualify for Medicaid, but because of their immigration status do not. These individuals have been in the fee-for-service Medicaid program up until now, but the state's transitioning them into Medicaid managed care. So they are doing that so in Cook County, what that effectively means is just about all of those individuals are being default assigned into county care, partially recognizing, that our health system has been a main source of care for that population up until now. And so if a member has a family member in another plan, the state will move them with that family member to the other plan, but otherwise individuals are moving into county care. So we're expecting to welcome about 40,000 individuals from this program from January to April. And we received the first just over 9,000 individuals in January. So we've been doing a lot of work in terms of outreach engagement. If you want to go to the next slide, Deb. We're also the only plan at this point that has come out with a decision to remove copays and cost sharing for this population, which is the same as we treat any other individual in our county care plan, that they have no copays or cost sharing. And we've also spent a lot of time focused on translation of materials, being thoughtful in our approach of how we will outreach and engage. And we've also spent a lot of time engaging with community partners to help share information and get feedback from them on things that we need to be thoughtful about as this population transitions in.
A point of clarification, why do you know the note that county care is the only plan that remove copays and cost sharing from this population? There are others in the county care that pay copays?
No, any member in county care does not have copays or cost sharing. However, individuals in the health benefit for immigrant adult program, if they are with another managed care plan, those other managed care plans are charging copays and cost sharing.
Yeah, okay, all right. Thanks for clarifying that. I was like, wait a minute, I know that we're not charging other people in county care, copays and they excluding this population. Well, once again, it's a testimony to the great work that you all are doing in county care that the state has opted to assign this patient population to county care as opposed to dispersing. By this patient population throughout the county, the other plans, the other MCOs.
Yeah, and I think it's important, and you already know this is a very special and unique population. They have language issues, probably housing issues in terms of having stable housing. Their status is such that they can't work. So whatever, it's good that we have a handbook, but it'd be nice to know what the plan is moving forward. Because this is a unique population within a population.
Let's just clarify the point, Aaron. We're not talking about, he's not the dual rival. These are individuals.
Migrants in general? Okay.
These are undocumented individuals who've been in a Medicaid plan. So this is the exception.
It is.
This patient population is different than the new arrival.
Okay.
Just to clarify that, in case those who are listening.
Correct. There could be some overlap. Some of the new arrivals could have enrolled in the program for some period of time. But yes, it's a combination of individuals because of their immigration status either being undocumented or if they are a legal immigrant who's been in the United States for less than 5 years. They do not qualify for Medicaid yet, so they can enroll under this program.
And this is something that I know you're going to take real hard, continue to watch this one very carefully. It's stated
It'd be nice to know where we are in 3 months.
Yep.
Aaron, I have one other question, and for this, I'm looking at the, card depicted here. It says a Medicare health plan. Is that accurate?
It's not,
I know it's
that's just
my
the
vision,
image,
but that says
we copied
Medicare
it,
health
so.
plan, I said,
I can definitely guarantee you our card does not say Medicare on it. And actually, we just updated that, copy of our card to also include something denoting there's no copays, just to help avoid.
I didn't know if this card were in people's
Confusion with
hands
other
for
plans.
Medicare, that needs to be correct.
But yeah, we'll update
Thank you.
our slide there so we don't, cause any concern. But yeah, certainly, the work here goes, well beyond the member handbook, and, back to your question, Director Harrington, a lot of focus here on, how do we initially engage with this population, to ensure that they're not just connected to care, but they're also educated on, the benefits that we offer as a health plan. A lot of individuals, are trying to navigate a complex healthcare environment, and we want to ensure that we can provide as much information as we can, and then, their preferred language. And, that's not just, while over half of the population is Spanish speaking, it's not only Spanish speaking. So, a lot of emphasis on, Mandarin, Arabic, Polish, so a number of different languages, that we've made our materials available in, and Alex and her team on the communication side have been incredible on the work that they've put in around this to ensure that we're being as supportive as we can possibly be. All right, and then the final initiative I wanted to provide an update. Are expecting the state of Illinois to go through the re-procurement of managed care organizations. So again, for context, we all operate in Medicaid managed care through a contract with the state of Illinois. The state of Illinois last went through their procurement process for this in 2017 when they awarded contracts for health plan years 2018 through 2022, and then there was a renewal for an additional 4 years. So our current contract ends at the end of calendar year 2025. So while no information is out publicly yet, we are expecting that, just kind of backing up the timeline, that they're going to be issuing an RFP likely spring of this year. So we've been doing a lot of work around this, and again, want to give a lot of kudos to our team who's put in a lot of extra effort besides their regular day jobs around this. We've started with the draft RFP the state issued previously, and then we've layered on new things that we know that they've been focused on over the past year, and developed an initial draft of what our RFP response would be. We're actually just completing a second draft version of that, which helps us just get prepared in terms of all the underlying data, a lot of the narrative, et cetera, a lot of review of our operations, our quality scores, all those things that we want to emphasize within an RFP response. All that just puts us in a strong position so that when the state does drop the RFP and we have 6 to 8 weeks to respond to that, that we are kind of reformatting and moving information around, but not having to develop a lot of new content, hopefully. So I think we're in a good position there. We also have some consulting support that'll be coming on to help us through that process that we're onboarding now. And like I said, we'll keep you posted on this, but we're expecting likely March or April that the state will potentially issue an RFP.
So Aaron, could you refresh my memory? Has a decision been made on who that consultant will be coming on board?
It is in process, so I don't know that it's final yet, but we can provide an update. Once that's done. Yeah. And I believe that concludes my presentation. I'm happy to answer any additional questions.
Any questions? No. Okay, thank you.
Thank you.
Aaron,
Thank you.
appreciate it. Okay, no action or motion is required on this information. It was only presented for general information. Moving down to the October 20th, 23rd meeting minutes. They were approved by the board at the October meeting, but are being presented for the committee's review and discussion. Are there any corrections that need to be made to the minutes?
None here.
Okay. So I'd like to entertain a motion to accept the minutes of the Managed Care Committee meeting of October 20th, 2023.
So moved.
Second.
It's been moved and seconded to accept the minutes of the Managed Care Committee meeting of October 2023. To the vote, all in favor?
Aye.
All opposed? The ayes have it. The motion carries. The agenda is exhausted and all items have been addressed, so I'd like to declare this meeting adjourned. Okay.